We have thus finished about final MBBS theory exam, final MBBS practical examination, and the next two post-internship licentiate examination. That leaves us with next one, or what I would like to still call it as the old-fashioned All India Postgraduate Medical Entrance Examination. What is the current pattern of examination? The current pattern of examination is usual 300 questions based on 21 subjects, starting from anatomy up to psychiatry. 4 positive marks for every question, 1 negative mark for wrong answer. The question that medical education restructuring curriculum wishes to ask is on the same lines as that of preclinical sciences. A student post MBBS after 4.5 years of MBBS, 1 year of compulsory rotating housemanship through all the departments, to almost every department, would definitely have had decided upon what broad specialty that he or she wishes to pursue. There is no doubt about this. There may be a doubt or there may be a debate between two broad specialties of the same genre, meaning under medicine, a student might not have had decided whether he wants to go for general medicine or pediatrics or emergency medicine or anesthesia. All of them are more or less similarly slightly related. Under surgical broad specialties, usually they would have decided about whether it is general surgery. It is very rare if a post-MBBS graduate comes and says that I am not decided whether I want to take up ophthalmology or ENT or general surgery or orthopedics. I mean, each of them being highly unrelated. So, 99%, almost 100%, I hope that I would not be wrong if I say, so they would have definitely decided on what broad specialty to take. This being the case, the question that NERC would like to raise is, if a MBBS doctor graduate has decided to study MS ophthalmology, why should that person, aspirant, study 21 subjects, most of which are unrelated? In other words, a person wishes to study MS ophthalmology, pursue MS ophthalmology. Why should he or she answer questions on orthopedics? If a person comes with a fracture after he or she becomes an ophthalmologist, is he going to treat me? If a person comes with a dermatological problem, is this ophthalmologist going to treat me? A person has decided to become an otorhinolaryngologist, meaning an ENT surgeon. Why should that person study about liver tumors and become regarding general surgery? Why should that person study internal medicine? Internal medicine is a broad specialty that we all know, and we're not saying that he or she must not have knowledge. Why should that person answer questions from nuclear medicine, from psychiatry? Why is the pattern of entrance exam, All India Post PG entrance examination, why is it a 21 subject PG entrance examination when the PGs would have applied or have decided what specialty they want to take? Immediately, I am aware that the viewers will ask a barrage of questions. In other words, what medical education restructuring curriculum wishes to propose is hopefully something that could bring a huge amount of joy and gladden the minds of all the post MBBS students who want to pursue post graduation. MERC proposes subject specific All India Postgraduate Medical Entrance Examination. That means to say that if a person wishes to apply for MS General Surgery, he or she, the student, the applicant, the aspirant, will be asked questions only on general surgery and all the pre and paraclinical subjects that are associated with general surgery. It is not the case that we are being centric. No. Anatomy with reference to general surgery, physiology with reference to general surgery, biochemistry which is relevant to general surgery, pathology which is relevant to general surgery, pharmacology which is relevant to microbiology which is relevant to general surgery and general surgery itself. So, same way, MD medicine, MD anesthesia, we have so many of these specialties. What MERC is trying to propose is that we must lessen these kind of an unrelated academic burden on the students. What do they do after studying these 21 subjects? They dump all these subjects. Exactly like physics, chemistry, botany. There is no difference between that. It is a parallel analogy. So if they are going to dump, why do they need to study? Instead, imagine a scenario where post MBBS they have entered internship. Let us assume that they have either decided or going to decide whatever it is. Having thus decided, a student wants to take up MD dermatology. For 1 year, the student would focus and concentrate on preparing for questions pertaining to dermatological medicine. What happens at the end of this? And of course, as I told you, allied preclinical, allied paraclinical, everything. Those MERC doesn't just say that it will. MERC doesn't mean to say that it will just be dermatological centric or anything like that. Or everything allied from preclinical, paraclinical, and clinical. What is the greatest advantage of such a system? The greatest advantage of such a system is apart from removing the unrelated, non-applicable subjects, the so-called 21 subject examination, the student at the end of 1 year is going to come out with, before entrance examination, the preparation is going to be so strong that the student would have, the applicant would have already he or she would have got an idea of the theoretical aspect of the subject completely in his or her hand. So once let us assume he or she clears the entrance examination and gets into the post-graduation of his or her choice, that PG would be right in the first year. His or her knowledge, the theoretical knowledge would be complete already because he or she would have finished studying the entire portion. All that the student will do is to just directly enter the course with complete a tank of knowledge and directly start applying it rather than in this present scenario where they enter with 21 subjects only having memorized A, B, C, D, E, all of the above, none of the above. That is all they would have memorized, and they will come and stand there on the first day of post-graduation. They will stand with a blank look on their face when they are asked why are the vowel sounds not heard in the abdomen. They would have absolutely no doubt. Only A, B, C, D, E, F will be. All of the above, none of the above will be floating in their front of their eyes and in their minds. Rather than that, if for 1 year, let us assume post-MBBS, a student has decided upon MD General Medicine, he or she focuses on Davidson's textbook of medicine and Harrison's internal principles of internal medicine and usual allied anatomy, allied physiology, biochemistry, pathology, whatever it is. As soon as he or she enters, let us say a diabetic patient is shown to him or her, that person would have had knowledge up to the brim. It is not the case that he or she the student has to be taught that this has to be done, these are the investigations has to be done, the meaning of FBS, meaning of 2 or PPBS, start from the scratch, start from HbA1c, what is a hyperglycemic crisis, what is a hyperosmolar non-diabetic ketotic coma, what is a acidotic coma, ketoacidosis, interpretation of ABG. You need not teach all this. For 1 year, the person would have focused only on medicine. Similarly, let us assume MS Orthopedics. 1 year, a student focuses on orthopedics. That's it. Therefore, this is the biggest advantage of having a subject-specific, the All India Postgraduate Medical Entrance Examination. Having thus proposed the subject-specific entrance examination, there will be many questions. There will be a barrage of questions, as I always say. At the outset, I would like to say two things. One, I'm just a cardiac surgeon trying to put across a proposal. I'm also an ordinary citizen. I have often repeated, there are much more brilliant academicians and educationists in our field, medical field. They would be able to answer some of these questions better. I might not be able to answer some questions also. One, this is a foundation I would like to put it. Secondly, before we go into the questions, which might question the basis of subject-specific PG entrance examination, I would like to first give the biggest advantages. Two advantages. One, drastic reduction of academic or educational burden on the aspirant. Instead of studying 21 subjects, all of them or most of them would be unrelated. As we have often said, student wants to join MS General Surgery. No point in reading about MS Ophthalmology. He or she is not going to treat patients, and vice versa. So, it will be a drastic reduction of academic and educational burden. One. Two, as already mentioned, the focus. The focus of the student will be on subject of his or her choice. So, either during internship or post-internship, whenever the student decides to sit and prepare for the All India Postgraduate Medical Entrance Examination, his or her focus is going to be completely and wholly and solely on one subject. Therefore, by the time the student comes out of the preparation and attempts the examination, and God willing, if the student gets the seat, as we have already mentioned, he or she would be absolutely, completely ready with all the theoretical knowledge and a theoretically sound foundation. And all that would be needed is to enter the PG course and start applying this knowledge to the clinical scenario. It is not the case that they join on the first day and start looking around and start learning then. No. Two massive advantages. And as an extension of the second advantage, even the faculty will obviously heave a sigh of relief. When you have a student who is brimming with knowledge about the subject, you are, as a faculty, as a teacher, as a consultant, you are on a slightly safer ground that you can confidently tell the student that such and such a case is there, you go and have a look. It is not the case that you have to debrief him or her right from the scratch. That would not be necessary. So, 2 or 3 huge advantages, massive advantages. One. The second clarification is, before we go into some of the tricky questions, complicated questions, the second clarification is subject specific. It does not mean subject centric, at least as far as clinical subjects is concerned. I hasten to say clinical subjects, meaning that people say, oh, you're going to, the subject examination is only going to be about general surgery, only going to be about orthopedics, that's it, OBG, psychiatry. No. Subject specific means all the allied preclinical, paraclinical, clinical, critical care, intensive care, and newer advanced research methodologies, innovations, all these put together will be, this is the composition, or this is what MERC means by subject specific. As already explained, student has applied for orthopedics, anatomy of orthopedics, physiology, biochemistry, pathology of orthopedic diseases, pharmacological drugs used
in the treatment of orthopedic diseases, microbiological infections of orthopedics, and of course, community medicine, community diseases with respect to orthopedics. Apart from this, critical care medicine, which will be a common factor as we will shortly display the placard, plus basic critical sciences and advanced research topics, newer advances. So, in effect, this will be not a single subject examination. It will be a 10 or 11 subject examination. Sorry for the word. Because 3 from preclinical, 4 from paraclinical, 1 community medicine, that itself become 8, critical care will become 9, and the subject in question that the applicant has applied for, that combined together will become 10 to 11 subjects. So subject specific is not subject centric. So from 21 subjects examination, this is a 10 subject or 11 subject examination with related allied topics. So this is one big clarification as far as clinical is concerned. Paraclinical and preclinical, I agree. MERC does agree that this will be subject specific because it is subject specific. Anatomy student who has applied for MS anatomy need not know about biochemistry. Student who has applied for MD physiology has nothing to do with microbiology. There may be some related topics that we are not denying those things. But to answer 21 subjects when a person has applied for MD physiology or MS anatomy, there is no need for that. This is the other clarification. Having said this, the major questions will be how do you propose to group these people? So grouping will be preclinical, paraclinical, and clinical. That means to say that when we talk of groups, preclinical will be a separate group. They apply for subject specific, and then they can apply for all the groups in preclinical, or they can even apply for paraclinical. We'll come to that later. But group-wise division will be preclinical, paraclinical, and clinical. 1. Starting the difficult questions. What if an applicant, aspirant, a graduate is undecided? He or she has not decided between MS General, MS Ortho, or MS OBG. No problem. Let us take 2 subjects. Simple. Let us go from simple to complex. The person can study both the subjects, prepare both the subjects, attempt both the subjects. In the application, MS General, MS Ortho. How will you conduct the examination? It is evident. Morning 9 to 12, general surgery. 12 to 1 break. 1 to 4 orthopedics. Same thing applies to everything. Person has applied for MD internal medicine and MD pediatrics. Morning, afternoon. Anesthesia and emergency medicine. Afternoon, morning. MD pulmonary medicine, TB chest diseases, and MD radiodiagnosis. Any combination, student can apply 2 subjects. Morning, afternoon. That's it. Over. Next difficult question. Next grade. Student has not decided between MD community medicine, MD internal medicine, and MD dermatology. How do you propose? It is not just 3 subjects. A person can apply even for 4 subjects. I mean, beyond 4 subjects, I would have to really say that after 4.5 years of MBBS, after 1 year of house surgery, if a student says that I have not decided whether I want to take up MD psychiatry or MS anatomy or MS ENT or MD internal medicine, then I think that student needs to introspect into himself and needs to have some counseling, pre-CET counseling. So having said that, even if a student wishes to apply for 4 subjects, student meaning graduate, there is no problem. All that would need to be done is to conduct the exam over a period of 2 or 3 days as deemed fit. Meaning that you conduct anatomy, physiology, biochem, path, micro, pharmacology on day 1. Next day, you can conduct ENT, community medicine, ophthalmology, forensic toxicology, so on and so forth. On the last day or 3rd day or whatever it may be, you can conduct MD internal, MD pediatrics. So, just as the same proposal, just as there is a proposal about NEET next one, if I'm not mistaken, that it is going to be an absolute MCQ examination spanning over 3 days, 540 MCQs, 120 or 130 questions per day, 3-hour examination. So that exam is being conducted over a period of 3 days. So with a foolproof data-based, computer-based examination, the question of leaks, that, this, etc. is absolutely zero. There is no question of that. In today's world of database creation, there is that cannot happen. And also, a person, all the students who wish to apply for MS Anatomy, they take it on day 1. They have also applied for MD Internal. You please attend on day 3. They have also applied for MS OBG. You can attend it on day 2. So we have 3 days or 2 days or whatever it is, whatever may be the permutation and combination. A student can attempt any amount of subjects of his or her choice, provided we configure this. We split the subjects on day 1, day 2, day 3. That answers the question. Having said that, there will be one more question. Instead of a 3-day examination, can it be a 1-day examination? Yeah, it can be a 1-day examination. 1-day examination, you can have a 2-subject or a 3-subject. How? If it is if the choice is narrowed to 2 subjects, as I already told you, as I already explained, morning session, evening session, afternoon session, it is over. Supposing you want to make it as a 3-subject and finish it within 1 day, then the only strategy or only thought process that MERC can think of, I may be wrong, I'm liable for correction, but from 300 questions, you reduce the number of questions to 200 or 225. Instead of 3 hours, you reduce to 1.5 hours or 2 hours. Does it make a difference? It doesn't really make a difference. Whether it is 300 or 225, or the competition will remain competition, marks will remain marks, and ranks will remain ranks. Reduce the exam time. 9 to 10:30, 10:30 to 12, same 12 to 1 lunch break, 1 to 2:30, 2:30 to 4 o'clock. 4 o'clock you are off, having attempted 4 subjects. What is the only rider? You reduce the number of questions. From 300 questions, you reduce it to, as I said, 200, 225, whatever is deemed fit, and reduce the time that is given. So, I hope that this has been a comprehensive answer for both the ends of the spectrum. You want to have a leisure, everything 300 questions examination, please go ahead and conduct it for over a period of 3 days. Each day, these subjects. All over India, whoever wants to attempt can attempt. On day 1, you have applied, your subject is there, you go ahead and attempt. On day 1, the subject is not, subject examination is not being conducted, fine, you have nothing to do with it. Everything needs to be finished on 1 day. We don't want any burdens, we don't want any slip-ups. You reduce the number of questions, you reduce the number of hours given for the examination, allotted for the paper, and finish it within 1 day. 9 o'clock to 4 o'clock, 4 subjects. Now, the last question that would arise is, student has secured a rank, let us start from preclinical. MS Anatomy, a student has secured some 2000th rank or 1000th rank. There are totally 150 or 200 seats all over India. What happens? Nothing happens. That is the performance. I can do no better than to quote my professor of anatomy from St. John's Medical College, Dr. V. Balasubramaniam, with whom I just now discussed. He's an anatomist par excellence. He's one of India's leading anatomists, a paper setter, an examiner. I asked him, sir, this is the question. Supposing somebody says, I have got 1000 rank, what will happen to me? I have written. That is your performance. You have not got a seat. You have to prepare better again and attempt next. That's it. In the same pool of preclinical sciences, can there be a crossover? Second question. That means to say, student has applied for MD Physiology, doesn't secure MD Physiology. MD Biochemistry seats are vacant. in the last round, mop-up round, 4th round counseling, 5th round, 6th round. There are so many rounds of counseling regarding which I'm not very familiar. But towards the last round, in a given pool, that is preclinical or paraclinical, let us start with the easy ones. If seats are left vacant, nobody, there are no takers, then can there be a crossover? Yes, because of the simple logic that one, it is a great sin to leave seats vacant. We are having a shortage of doctors, postgraduates in almost all the disciplines, especially preclinical, paraclinical, whatever it is. If a person has applied for MD physiology, a seat of MD biochemistry is vacant, no takers. Can that student be permitted? Yes. It should not be argued that how can a person who has written MD physiology entrance be qualified to get MD biochemistry seat? That person is an MBBS graduate. He or she has studied MD. He or she has studied both physiology and biochemistry. It is not that he or she is alien subject. Biochemistry is not an alien subject. I mean, when you come down to brass tacks, it is not the case that it's an alien subject. By choice, by interest, by passion, that person has applied for MD physiology. Unfortunately, person has not got it. He or she, instead of his or her thought process may be, I'll attempt again, fine. Other thought process may be, instead of wasting time, if there is a biochem seat available, I'll take it. So, the answer to this question is, within the group of preclinical and paraclinical, same thing. MD pathology did not get the seat, microbiology seat is vacant, or pharmacology seat is vacant, no takers, final round of counseling, seat is vacant. If the person wishes to take, fine. There should be no objection. There should be no objection. So, this clears the air about intra-pool crossing. So, the same thing, extrapolating the same thing to paraclinical sciences. Student has applied for MD pathology, has not secured a seat due to the virtue of his rank, as a result of the rank. So, MD microbiology, all rounds of counseling are over. In the last round of counseling, there is a MD microbiology seat that is available, or an MD pharmacology. Can this person opt for, considering that it is going vacant? MERC feels that instead of a seat going vacant, it is prudent to fill the seats. Instead of we going on lamenting that there are no graduate, there are no postgraduates, there are no MD, whether it is preclinical, paraclinical. We can perhaps extend the spectrum and ensure that seats don't go vacant. So, intra-pool transfer. So, a person writes for anatomy, opts for biochemistry when he or she doesn't get it, if a seat is vacant. So, that I think should be, that MERC feels should be okayed, should be granted. Next level of difficult question. Inter-pool transfer, at least as far as pre and paraclinical. That means to say, extend it a little bit more. Student has applied for MD biochemistry. He or she has not secured a seat. There is a seat of MD pathology that is vacant. Can we give the seat? Two scenarios. Absolutely vacant, fine, take it. But suppose there is a competition, there is a tie-up. How will you sort this tie-up? That means to say, I might be wrong with the word. There are two students, one has written for MD pathology, another has written for MD biochemistry. Both have got some ranks. Let us assume, out of 5,000 people for biochemistry, this candidate has secured 4,000th rank. The person who has applied for MD pathology, even he or she also has scored, let us say, 4,100th rank. Who deserves the seat? People will say the 4,000th rank. No. The question remains. A part of the question still remains. 4,000th rank out of 5,000 applicants. Pathology, I did not say. He or she has secured 4,100th rank out of 10,000 applicants. Out of 10,000 applicants, he or she has managed to secure 4,100th rank. Whereas only out of 5,000 people, this person has secured 4,000th rank. So he or she is relatively, there'll be a concept of relative ranking. So when crossover, interpool or intrapool crossover between preclinical or paraclinical, there is a situation, then the concept of relative ranking has to be taken, and a relative rank has to be created. That means to say, already the viewers can understand, out of 5,000 applicants, this person has got 4,000th rank. Out of 7,000 applicants, this person has got 4,100th rank. Who is a greater rank holder? So, using this concept of relative ranking, the seat can be allocated, even if it is interpool transfer or intrapool transfer. Lastly, we come to the slightly difficult topic, and that is a question rather. Within the gamut, within the umbrella, within the parameter of clinical subjects, if this situation arises, what are your options? That means student has applied for MD Internal Medicine, MD Pediatrics, MD Dermatology and MD Psychiatry. No seats available. Student has got some rank. The student has not secured anything. So can the person opt for something else, MD Pulmonology, MD, provided there is a seat? Again, the same concept has to be extrapolated. It cannot be the case that, it should not be the case that question should not be asked, and that is, he has written internal medicine, there is a seat of radiodiagnosis. How can you compare? Subject is a subject, performance is performance, marks are marks, rank is a rank. Relative ranking, yes, that will be there, but it cannot be the case that there is a person who has got first rank in psychiatry, there is a person who has got first rank in internal medicine entrance examination. Who is greater? Both are equal. There is a person who is a professor of pediatrics, there is a person who is a professor of emergency medicine. Who is greater? Everybody is equal. Every subject has to be respected. Every subject has its own pedestal of importance. So, having said this, I hope that within the limitations of my knowledge, I hope that I have put across all these permutations and combinations. There will be more questions. I do not deny that. There may be many more questions. I forgot what one of my colleagues, who's a professor of pediatric cardiac surgery, he asked me one question. Dr. Mouli, when you speak of subject-specific entrance examination, there will be one major problem after 5 years, and that is, how do you frame question paper? The subject will be limited. One subject, it will be limited. So after 4 or 5 years or 5 or 6 years, you will have to start repeating the questions. The answer to this question, what I was able to think of and discuss with him was, when it comes to clinical, we have already made it clear that it is not subject-centric, it is subject-specific. It is not 21 subject, definitely. But when you take ENT, right from preclinical down to clinical advanced topics, it will be a 11 subject examination. So you will have ample amount of material to keep the machinery going for years and years together. One. Definitely, when it comes to preclinical and paraclinical, it will be subject-centric. I do not deny that, because as person has applied for MS anatomy, there is no rationale behind asking biochemistry questions. That person is not going to. How do you tackle this? Even let us take MS anatomy. It is an ocean. It is a galaxy. Embryology, histoanatomy, histological anatomy, microscopic anatomy, gross anatomy, surface marking, embryology, genetics, and radiological anatomy, osteology, cross-sectional anatomy, kinesiology, advanced topics. How much more? I mean, as I have said before, I have done my undergraduation and post-graduation from St. John's Medical College. When we visit any library, I'm just telling you, when you're in St. John's Medical College Library, for anatomy, there are hundreds and hundreds of books. They are enough to set the papers. Even Gray's Anatomy itself, Destin Taylor Physiology, they are enough to set the papers going on and on for years and years and together. Therefore, this is how, I just gave one of the examples one of the questions that I forgot I have included in the last. So there will be questions. MERC may not have answered some more questions, especially with regards to some, tricky questions regarding seat matrix, seat distribution, etc., etc. But the one unambiguous, unchallenged advantage of subject-specific examination will be, that cannot be denied, is if a student has chosen a particular subject or subjects, this unrelated, unconnected 21 subject educational academic burden will be totally removed. This is undeniable. Student will focus on preparing the subject of his or her own choice and attempt the examination. One. The second, as already outlined, even before joining the post-graduation course, if God willing the person gets a seat, then the person would be fully, at least near totally prepared with a huge foundation of theoretical knowledge that is necessary for the PG course, for that particular specific subject. And that person, that student, that candidate will be ready to apply this knowledge into the PG course as and when it is needed.
This being the case, on your screens, I'm going to present a small model. Obviously, as I always say, our nation has got a stalwart of teaching faculties. This can be suitably modified. If as I keep saying, I'm an ordinary civilian, we are all already ordinary civilians. So if the government finds that this is suitable, and if this particular scheme is implemented, then this would be the pattern, a proposed pattern of All India Postgraduate Medical Entrance Examination question paper model. There are 3 models, one for preclinical, one for paraclinical, and one for clinical.